So welcome everyone to HIV and AIDS, what every optometrist needs to know. We have a wonderful speaker here tonight, Dr. Sowka, and I'm going to be your host and moderator. We also have Vanessa on as our ARBO administrator and optometric education consultants administrator. With that being said, Joe served as a professor of optometry. It's probably when most of you know him from is from at Nova Southern University College of Optometry. He was there for about 28 and a half years. There he was chief of advanced care service, director of glaucoma service, and chair of Department of Optometric Services. Joe is also a creator, a founding member of the Optometric Glaucoma Society and Optometric Retina Society. He also is the chair of neuro-ophthalmic disorders in optometry for the American Academy of Optometry. So he's done a lot there, but he's also a gifted writer, hundreds of published articles. He's the lead author of the annual Handbook of Ocular Disease that is distributed via Review of Optometry. Joe's a gifted writer, but we're going to find out tonight that he's also a gifted lecturer, known national and international lecturer. Recently, as you can see on his slide there, Joe has moved to Sarasota, Florida, where he's working for Center for Sight. With that all being said, let's give a big virtual round of applause to Joe. Joe, thanks for being here tonight. I'm going to distribute the handout. I'll watch the questions, Joe, so please take the pilot seat.
Thank you, Greg. And as you mentioned, the publications, just a reminder, just a personal note, you and I have a chapter coming due in a couple of weeks. I keep forgetting to mention that to you. I'm sure you know that.
Okay.
All right. Disclosures. I'm on a number of speakers bureaus or advisory boards for different pharmaceutical companies. I own this company, Optometric Education Consultants with Greg, but of course, there's nothing pertinent to my lecture tonight. Now, HIV, I want to go through the stages of our understanding because it certainly has changed throughout, my career here. And we started off what I call AIDS in the Dark Ages. And this came from Gary Holland and Associate. This was in American Journal of Ophthalmology, one of the most prestigious journals we had. He was writing on ocular disorders associated with this new severe acquired cellular immunodeficiency syndrome. We see when it is 1982. And in his manuscript, they talk about prominent features of a newly described acquired cellular immunodeficiency syndrome that affects previously healthy male homosexuals with multiple opportunistic infections and Kaposi sarcoma. And their conclusion, and what they wrote in this big journal, was that immunosuppression induced by cytomegalovirus infection may play a major role in the pathogenesis of this disorder. It was entirely backwards. Now, during my training in the mid 80s and late 80s, we see a patient who was HIV positive or maybe even with the development of AIDS at the Eye Institute at PCO. And we would not wear gowns, but we would often wear gloves at that time and to do an eye exam. And when the exam was over, I remember they put up like crime scene tape and the maintenance crew would come in with buckets of bleach and wash the walls and the ceiling and treating like Ebola virus or coronavirus. Now we look at AIDS like diabetes and HIV infection like diabetes. It's a chronic disease. There are medications and lifestyle alterations that are going to increase longevity. There are some ocular complications which are becoming actually kind of uncommon. And most of these patients can live a normal lifespan and some aspect of their infection may contribute to their death. Greg, we're going to start off with polling question number 1 already.
Perfect. And while I'm launching that, Joe, we got a little text message from Vanessa that we have about 50 people without cameras on. Please get your camera on.
If you're getting Florida credit, please.
Yep. Yes. Florida credit. You want to make your little comment, Joe, in case they're having issues? We have different ways of monitoring.
Yeah, we're certainly monitoring log in, log off by your ISP address. So where is the greatest population of people living today with HIV? Is it Europe, Africa, Southeast Asia, or North America?
Everyone, this is part of live and interactive, so please, your guys are rolling in beautifully here. I see the numbers flying in. Just a reminder, um, we're allowed to be doing these, and we don't want to create any problems. So, all right, we're getting there. A couple more, and we'll end the poll here, Joe. I think we did well.
Very well. Yep, we did. 93% responded. So we're gonna share the results, Craig.
Yep, I'm gonna do it right now.
And the highest is report was Africa.
And Joe, I want to also let the audience know that the handout is in the chat box. It's downloaded or to be downloaded for those who want it. It's also as a link in the 645 email.
Excellent. Well, what is AIDS, acquired immunodeficiency syndrome? And of course, and this is a required course for first renewal. We have a lot of relatively new graduates renewing for the first time. This is a required course. Otherwise, you can take it for general credit. And we have to talk about not ocular manifestations, but the life cycle, transmission, prevention, and treatment. So we're not going to be talking about ocular manifestations. This is a complicated assortment of secondary disorders that result from infection from the human immunodeficiency virus, the HIV virus, which selectively attacks the immune system, and specifically the T helper CD4 T cell lymphocytes, and destroys a cell along with other cells. And it's going to be transmitted via bodily secretions. Now, according to the World Health Organization, there's about 37 million people worldwide living with HIV at the end of 2017. And the stats I'm giving you are really the most recent. It takes a long time to collect these statistics. Now, AIDS deaths back in 2007 were about 2.1 million per year, or about 4 deaths per minute. In 2017, it's about 940,000 deaths per year, about 1.8 deaths per minute, essentially halved, cut in half. Now, out of 37 million people living with HIV, that's about 14% more relative to 2010, because people are living with it. They're not dying with it. There's a decrease in the number of new infections annually relative to 2010, mostly because of pre-exposure prophylaxis, which is now available. And the deaths have decreased by about 34% relative to 2010, which was why there are more people living with the disease, because the medicines are plentiful and very effective. Now, out of those 37 million people living globally with HIV, by far, it is Africa. It's about 26 million people. The Americas, about 3 million. Same thing for Southeast Asia, a little bit less for Europe, Mediterranean, Pacific. So by and large, it is people living in Africa. Now, from 2010 through 2016, in the U.S. and the dependent areas, the number of diagnoses of HIV infection among female and male adults actually decreased. From 2010 through 16, people of color, African Americans, accounted for the largest percentage of diagnoses of HIV each year in the U.S. and the dependent areas. And in 2016, about 40,000 adults and adolescents received a diagnosis of HIV infection. And of these, about 81% were male and 19% were female. So it was by and far more common in men. Now, looking at transmission categories and how this is actually transmitted through the U.S. and the dependent areas, in men is by far male-to-male sexual contact, much less is heterosexual contact, injecting drug use, and of course, male-to-male sexual contact and injecting drug use. Now, females, by and large, is heterosexual transmission. And injecting drug use is quite a bit behind that. If we look at the rates of diagnosis of HIV infection at age of diagnosis, It's pretty steady and increased a bit in the younger group of 24 to 34, and we can see over the age of 55, it is actually relatively low and relatively flat. Now, the mean age of death due to HIV infection from 1987 to 2015, in the early 80s, it was on average about 36 or 37 years old. In 2015, it was well above 50. And the reason is at this early stage, there was a poor understanding of the disease. There were very few or no treatments, so the treatments were very harsh on people. But right about here, we started to see a big change in the longevity due to something called protease inhibitors. And this is really the peak of where the medicine effectiveness came in. We can see that in the late 80s and early 90s, and this was about or virtually neck and neck with accidents in terms of cause of death, out of the leading causes of death. And right about here, there's a precipitous drop so that it is actually one of the lower causes of death. And this is about when the protease inhibitors were developed, and they were extremely effective in managing HIV infection. Now, Florida is number 5 in the U.S. and people living with diagnosed HIV infection at the end of 2016. District of Columbia was number 1. New York, Maryland, oddly enough, the Virgin Islands and Florida is number 5. So when we look at the map, rates of adolescents and adults living with diagnosed HIV infection 2016 across all the areas, you can see there are some hot spots. Florida, the Southeast, South, very, very metropolitan areas, New York, California, Nevada as well. So in the Midwest, it's a significantly lower number, but there are obviously a few hot spots here. Now, after rapidly increasing through the 80s, the rate of death due to HIV infection peaked about 94 and 95, depending on what group you look at, and then decreased rapidly through 97. And it decreased much slower thereafter. And that's because, I said, again, the protease inhibitors. They were a very effective category of medicine that came out. Now, people dying from HIV infection increasingly consisted of women in 2015. More women were dying of it. People of color, very, very high representation. Residents of the South, right? And when we say South, is good, and when we say that is, if we look in the southern states, there is a high population of HIV infections. And people 45 years or older, that was increased by about 75%. So it still continues to be among the 10 leading causes of death among people ages 25 to 44, particularly people of color and people of African descent, African Americans. Now, what is it and what is it all about? The HIV is a family of slow viruses, or what is known as retroviruses. And if we go back to biology, in terms of cellular replication, it was DNA to RNA to DNA. But this is a retrovirus. It goes from RNA backwards to DNA. And the HIV RNA will take over a cell and start using that cell to manufacture viral particles. So rather than go from DNA to RNA, this is reverse. Retrovirus is RNA to DNA. It will bind to the host cell, including the T helper cells or the CD4 cells, macrophages, histiocytes, and other inflammatory cells, and it's going to kill them. Now, the life cycle of HIV. What happens is the person acquires an HIV infection, and it's going to be through the transmission of serous fluid or bodily fluids. And there is a seroconversion. Now, this is a very asymptomatic stage, and there's a high degree of viral replication, and the patient is having antibodies. And they become symptomatic at about 2 weeks, and that's symptomatic for a flu-like illness. Sometimes moderate, sometimes it is a little bit more aggressive. But at this point, the immune system is still pretty robust. So the patient is going to develop immunity with this profuse viral accumulation, and it's going to suppress it's going to suppress the virus, and will partially, not totally, but partially clear the virus. And the patient will go into an asymptomatic stage, which can last 10 years, 10 years or more, sometimes shorter, sometimes longer. And people who are in who were in high risk situations, who weren't getting tested regularly, were carriers. They transmitted it. Now, after this period of time, whatever the period of time is, 3 years, 5 years, 10 years, 18 years, the immune system is going to wear out. And now the virus starts to replicate more. When that happens, the CD4 cell count are going to drop. The patient becomes symptomatic. The immune system is no longer working efficiently, and they develop opportunistic infections, Kaposi sarcoma, cytomegalovirus, acute retinal necrosis, herpes infections. And when that happens, it's said that they now have AIDS. So in the acute phase, what do we see here? The viral load is nothing until there's a transmission of the virus and a quick seroconversion with profuse viral replication. And it catches the immune system off guard, but then the immune system starts to kick in, and it's going to beat down that virus. It's going to get it to a set point of replication, which may be high, but is often actually relatively low. Now, at this time, the immune response or immune system is normal, it's healthy, and the CD4 cell counts are numerous, but they get overwhelmed. Then they start to recover, and when we get to this quiescent period right here, is what is known as the chronic phase. And as time goes on, more CD4 cells die, and that allows the virus to replicate. Now the viral load comes up, the CD4 cell comes down, the immune response is insufficient, and now this insufficiency, the virus is killing more and more CD4 cells. The immune response is insufficient, and now patients are susceptible to opportunistic infections. And it's the opportunistic infections such as toxoplasmosis in the brain, or cytomegalovirus in the brain, or pneumocystis pneumonia that actually kills the patient. And these are things that we're all exposed to, but we don't suffer from them because we have a healthy immune response. Now, the virus is never dormant. It's always going to be replicating, but at a set point, which is controlled by the immune system. If the immune system is robust, the set points can be relatively low, and they can be into a quiescent period for a very long time. Now, replication of the virus is going to damage the immune system, and as that breaks down, pneumocystis pneumonia, Kaposi sarcoma, toxoplasmosis, cytomegalovirus, these are all things that we're exposed to, but our immune system can combat, well, can no longer combat it, and these are what kill the patients. So the HIV is going to bind and fuse with a host cell. The most common one is the CD4 cell. It's going to release viral RNA into the nucleus of the host cell, and this viral RNA is going to infect the T lymphocytes as well as the glial cells and monocytes and histiocytes. And viral RNA is going to be incorporated into the cell. Now, an enzyme called reverse transcriptase is going to form viral DNA from the viral RNA in the reverse fashion. That's why these are called retroviruses. Then an enzyme called integrase is going to integrate the new viral DNA into the host genetic DNA material, and it's going to take over. So the cells are now going to start making viral genetic material and viral particles. And these viral particles are going to be acted upon by an enzyme called protease, and that's going to form them into new viral cells, which are going to be released to kill adjacent healthy cells. And this is a diagram of what I just talked about. It's going to fuse, and there are some criteria for the virus to be able to fuse into the cell, through the cell membrane. It's going to release its viral RNA. This enzyme, reverse transcriptase, is going to create viral DNA, and that viral DNA is going to be incorporated into the cell's normal DNA by integrase. And then the cell is going to be creating viral particles that are going to be released, and protease is going to form them into new viral particles, which will now be distributed or dispersed to infect other cells. And where are the treatments located? Well, enzymatically. Enzyme inhibitors are here, here, and here. Protease, this was very effective. Reverse transcriptase was effective. Integrase is not terribly effective. And the other place where therapy is being directed is now trying to prevent adherence and fusion. So if a cell can't get in, it can infect the cell. And these viral particles are actually very susceptible when they are outside an inflammatory cell. They can replicate up to 10 billion particles a day. We want the viral load to be under 10,000 copies, and best under 200 copies. When we have it under there, we consider that to be undetectable. Now, people with undetectable viral loads still will have the virus in the semen and may may cause infection. Now, as of 2017, authorities agreed that those with undetectable viral loads effectively cannot transmit the virus. The CDC released a statement that those taking medication and maintaining an undetectable viral level have effectively no risk of transmitting the virus to an HIV negative partner. And they had this phrase called U equals U, undetectable equals untransmittable. So with some modifications of behavior, medications, and keeping the viral load at an undetectable level, it is thought to be they are not going to be transmitting the disease. Now, in the life cycle, the highest titers are going to be in the primary stage, which is about the first 14 days. Patient becomes symptomatic with a bit of a flu-like illness. And this is when they're most likely to transmit the virus because there's no antibodies. The immune system is caught off guard, and the viral replication is very high, and patients may not be aware of the infection. And they get this retroviral syndrome of fatigue, fever, sore throat, nausea, muscle pain, and it's not tremendously debilitating. But the symptoms seem to equate to the viral load. So if they're very symptomatic, they may actually have a very high viral load initially, and a high viral load is actually pretty predictive of actual progression relatively rapidly through to full-blown AIDS. Now, AIDS is emphasizing the CD4 count in categorizing the HIV-related problems, and the CDC has expanded the case definition. Now, progression from infection to AIDS can be as short as 8 months or longer than 18 years. And there are long-term non-progressives where the viral load stays down and T cell stays up. Just like glaucoma patients, there are rapid progressors and there's slow progressors. Now, the long-term non-progressors, the viral load is going to stay down and the T cells stay up for quite a long time. Then there are rapid progressors where the viral load's initially high and the T cells are low, and they can progress rapidly through to AIDS. The good news is rapid progressors can actually be turned or converted into long-term non-progressors with the medicines that are available. Now, looking at a study of blood frozen early in the disease back in the mid-80s, those who had a viral load of less than 3,000, only about 10% developed AIDS. Now, those with a high initial viral load of over 100,000 or 110,000, about 3/4 of those patients developed AIDS. So a high initial viral load is the most predictive of AIDS development, and a high viral load 6 months after infection predicts a rapid progression. But as I said, fortunately, these patients can be converted to long-term non-progressors with medicines. So it's going to have a self-limiting flu-like illness, upper respiratory infection for about 2-week duration. And they get in this asymptomatic course of months to years until the immune system becomes depressed and opportunistic infections take over. Now, defining AIDS by CD4 count, it's CD4 T lymphocytes below 200 or the development of secondary infections. So either of those or together marks the definition of actual AIDS, no longer HIV infected, but have developed AIDS. Now, I'm not going to talk much about AIDS in the eye, but understand that the CD4 count is less than 200. In the first year, there's about a 1 in 3 incidence of opportunistic infections developing in the eye. In the second year, almost 60% of chance of having an opportunistic infection, such as zoster or cytomegalovirus or toxoplasmosis. And if the CD4 count is less than 100 in the first year, there's about 25 incidents the patient will develop CMV retinitis. So follow up on these patients with no retinal pathology. If their CD4 count is above 600, annual exam. 300 to 599 twice a year. CD4 299 to 100 every 3 to 4 months, less than 100 every 2 to 3 months. If they have a systemic CMV infection every 2 to 3 months. So if the CD4 count is high and the viral loads are low, it's an annual examination like a diabetic who has no retinopathy. Greg, that brings me to polling question number 2. And this is for you all to say to yourself, I have seen an HIV-related ocular condition within the past 2 years. Do you agree or do you disagree?
Nothing's in the chat box, Joe, just so you know.
Okay.
No questions, no comments. And that's a reminder for those who are out there. If you do have comments, that's part of the live and interactive. Please put your chat questions or put your questions in the chat box. All right. So it looks like we got a high number here, Joe. So I'm going to. And now it's shared. Okay.
And the majority of people have not seen an opportunistic infection related to HIV in the last 2 years. I agree. I don't think I have. Greg, have you?
I have not.
And that's just due to the improvements in transmission and treatment of the disease. So talking transmission prevention, testing, reporting, and management. Greg, it brings me to polling question number 3 already.
Oh, quick. Here we go.
Tears are a significant risk factor for HIV transmission in healthcare workers. Do we agree or do we disagree with that statement?
Going to have to give kudos to this crew here tonight. This crew pays attention and gets ready for the polling questions. Definitely the fastest out there for 28 seconds and about able to end this poll, Joe.
And I think a lot of people have experience because I see a lot of frequent flyers out there in our audience today.
So I'm going to end it and I'm going to share it, Joe. And the results are shared.
Mm-hmm. And most people agree that tears are not a significant risk factor for transmission to us as healthcare providers. Now, HIV can be isolated from blood, semen, and vaginal secretion, CSF, synovial fluid, pleural pericardial fluid, amniotic fluid, and tears. It is in tears. And transmission is by exposure of mucous membranes to visible blood or body fluids, blood transfusion, sexual contact, sharing needles with IV drug users. There's a negligible risk of HIV transmission by exposures of the vagina, rectum, eye, mouth, or other mucous membranes, intact or non-intact skin, or with urine, nasal secretion, saliva, sweat, or tears, if they're not contaminated with blood. Now you can take, on my arm, I can take blood that is HIV infected and pour it on my skin, and nothing's going to happen to me because it's not going to get through my dermis. And tears, while there is HIV, the virus is in tears, it unless there's blood with it, it's very negligible transmission. Needle stick is the most common, about 51 cases, or probably more at this point, of transmission and conversion have occurred in healthcare workers. So everybody has to be using what are known as universal precautions in HIV infected samples. Back in the 80s and early 90s, in surgery, people are taught every move must be deliberate. Hand washing, soap and water after each patient, dry with a fresh towel. Gloves, discard after each patient. Double glove if there's a risk of needle stick. Now, is a double glove going to prevent a needle from going through? No, but it's going to help wash off or remove some of the inoculum. And gowns and masks are not usually necessary for any sort of routine examination. There's no expected blood splashing. Disinfecting Goldman tonometer and gonioprism. Okay, alcohol, white, wash with water, or soak in hydrogen peroxide for 5 minutes, or soak in bleach. HIV is not hardy. Outside the body, it doesn't live very long. Now, in Florida, the state has to facilitate informed, voluntary, and confidential HIV testing. It also has to provide counseling and anonymous and confidential services. Results of testing can't be used, certainly in the state of Florida, to determine eligibility for disability, health, or life insurance, or to screen somebody for a job. Now, HIV testing has to be prefaced by informed consent, and the patient has to understand that all tests are confidential, but they're going to be reported to the health department, and they're anonymous testing that patient can avail themselves. So anybody ordering the test has to inform the patient, of the test results, as well as treatment and support services, understanding how to prevent transmission and notifying partners, and can only be released to a legally authorized representative. And if we violate any of this, is a first-degree misdemeanor. And it's illegal for any medical facility to require or utilize HIV testing as a condition for admittance or treatment. But all sexually transmitted diseases have to be reported to the Department of Health within about 2 weeks. Now, when if we were to order HIV testing or an HIV test, we have to have the ability to counsel patients before and afterwards. And in many cases, many of us don't have that experience. That's why you would order this or recommend this to a patient's primary care physician. Now, case history questions: when were you first diagnosed? Have you been treated for any infections? What medications are you taking? Are you compliant with your medicines? When was your last blood work? What is your cell count, and what is your viral load? These are the two that they usually will be able to tell you. And if they can't give you those numbers, you have to be concerned that they are not taking their disease seriously, or they're not adherent to their therapy. Now, management of HIV infection. Goals: keep the viral load as low as possible. Now, you may never get to an undetectable level if it's really high, but they want the CD4 count as high as possible, and any opportunistic infection to be properly managed. There is a time when it was said, if you understood syphilis, you understood medicine. Now the phrase is, if you understand HIV and AIDS, you understand medicine. And there are people who have specific skills. There are people who specialize in HIV medicine and AIDS treatment. Now, there's a lot of medical therapies and a lot of good medicines out there. First off are the nucleoside reverse transcriptase inhibitors. These prevent infection of new cells, is incorporated into the viral DNA, and prevents further synthesis. And the first one that we had, and that was AZT. That was the first one. It had a certain degree of effectiveness, but it certainly was not sufficient to treat most patients. And since then, there have been a lot of other medicines. Lamivudine is out there, tenofovir, Viread, very important medicine. Crixivan is a Combivir is a very, very common combination medicine used for HIV. And the non-nucleoside reverse transcriptase inhibitors will directly inhibit reverse transcriptase. It inhibits this enzyme right here. And common ones are Virimune, Rescriptor, and Sustiva. Now over here are the protease inhibitors. These prevent assembly of the new virus cells. And this leads to a dramatic reduction in viral load. These came out in the early 90s, and they increased survival rates enormously because they were so effective. And there are a number of medicines out there. Crixivan, very common. Viracept, very common. Kaletra is another one. Inverase, these are all very common medicines, both alone and in combination. So here's a great place where they've worked, and here's a greater place where they've worked, but integrase inhibitors have not been especially effective. Now, patients undergo what's called heart therapy, I think I turned my sound down a little bit, highly active antiretroviral therapy. I'm not going to go into all of the details because we don't treat it. Suffice it to say, it's a cocktail of a lot of stuff. And they can be medicines within the same family, convergent therapy, medicines in different families, divergent therapy, but it's a multiple cocktail that has been used. And it's very unforgiving of non-adherence to drug schedules. If there's a non-adherence to drug schedules, resistance will occur. Monotherapy alone is generally not really well thought of due to the possibility of resistance, and drugs are generally not titrated up. They're put on polytherapy immediately. And when the viral load is high, they're going to need more medicine. Now, most practitioners don't believe that deferring therapy is acceptable, but there are some specialists who, if the viral load is high and the CD4 count, viral load is low, the CD4 count is high, they'll do a short-term monitoring of the patient without therapy. But these are AIDS specialists. Combination therapy is generally the patient's best option, but there are some monotherapies out there that are very effective now. And I said we can have convergent and divergent therapies. But patients can't miss dosages regularly because it will lead to resistance. There's about 1 million mutations daily. Drug failure is the development of opportunistic infections, decreasing T cells, increasing viral load. And when this happens, usually it wipes out the entire heart profile, and they have to start new drugs, all new drugs. Just can't swap one out. Now, one of the newer medical therapies are the fusion inhibitor, Fusion. This was, in March 2003. And you don't hear about it a lot because it never really caught on and doesn't have a great effectiveness. But it's trying to block HIV from fusing with the cell membrane. But there are other ways that this can be prevented. Integrase inhibitors, Taviki, Vitketa, these are medicines that are out there. We don't hear much about them because they have a relatively low effective rate. Now, some of the new ones that we've probably actually heard are Descovy. Right? This is a prodrug. Right? This is a prodrug of Viread, and it will allow a greater concentration of tenofovir to be accumulated. So it's a prodrug. It lowers the amount of HIV in the patient's blood more efficiently than the older antiretrovirals. It is very effective at about 1/10 the dosage. So this is a prodrug that puts a high concentration of tenofovir in the patient's cells. But looking at it, we see the price. You know, a month's therapy is almost $1,700. Genvoya and Eldefsi. These are two new medicines. These are combination medicines that are once a day dosing. Now, previous heart therapy meant the patient would have to gobble pills throughout the day. And they had to be very, very regimented as to when they took these pills. Now we have combination therapies that are once a day dosing, and they're actually very, very effective. Genvoya is a complete regimen. It's a combination regimen, and it's been very effective. I had a patient a few weeks ago who was HIV positive, who was using Genvoya, and he had been HIV positive probably well over, at this point, 20 years, and he was very easily living with the disease, and he was using Genvoya once a day, and it was very effective for him. But a problem is, we see the cost. It's almost $3,000 a month. But there are programs through the drug company and other foundations that allow patients to get these medicines at a reduced price, and he was able to get it at a reduced price. As he said, if not for that, he would never be able to use the medicine. And Eldefsi is almost the same. It's about $2,600. So these once a day, very effective combination medicines are fabulous, but they are fabulously expensive. Now I'm going to talk about a couple things. Post-exposure prophylaxis, or HIV PEP. Needle stick can be a serious issue. However, I mean, after tainted blood transfusion, a needle stick is the second highest exposure rate. But the conversion to HIV to a healthcare worker is about 1 in 300. Now, that's dictated by how much inoculum gets in and what is the patient's viral load. And there's like 50 to 60 documented transmission and more possible transmission. Now remember, the virus is not hard. It's killed by most antiseptics when it's exposed. But should an exposure occur, if it ever happens to anybody out there, and hopefully it's not likely, but post-exposure prophylaxis is very important. There are a number of medicines that are going to be used, but the most important thing is 72 hours. To be effective, this post-exposure prophylaxis has to be within 72 hours of exposure. So you have the healthcare practitioner, I hope nobody out there ever experiences this. You got to get to your doctor's office, the emergency room, or an urgent care clinic or a local HIV clinic within 72 hours. Now, what happens if you get a needle stick? You soak it in betadine, peroxide, alcohol. You don't chop off the digit. If anybody ever saw the movie World War Z, where the Brad Pitt character, one of these soldiers gets bit by a zombie and he chops her arm off, you don't do that. That only prevents zombie formation. It doesn't prevent AIDS. You don't chop off the digit. But you need to have HIV post-exposure prophylaxis within 72 hours, and it's going to be going for about 4 weeks. Now, you can't test the patient's blood for HIV after needle stick without their consent, though. So you have to assume that it is HIV infected. So the basic regimen is going to be a number of things. Basically, Combivir. Combivir, one tablet twice daily for about a month, is going to significantly reduce the transmission. And the transmission is going to be very, very low. Truvada or Descovy can also be used. But fortunately, the medicines for post-exposure prophylaxis are actually relatively inexpensive. Now, we have to consider pre-exposure prophylaxis, and this is a very important part of HIV at this time. And this is, treating a person before exposure to prevent disease. An example would be malaria. People who are going to go into a malaria endemic area will take chloroquine medicines in advance. So theoretically, if HIV can be in replication can be inhibited from the very first moment it enters the body, it may not actually establish a foothold. Now, CDC has sponsored a number of safety trials using tenofovir or Truvada. They initially used 3 populations at high risk were heterosexual in Botswana, injection drug users in Thailand, and men who have sex with men in the United States. And the efficacy was actually relatively poor because of poor compliance. But they did a partner prep study in Uganda, which actually looked at heterosexual couples where one was infected and the other is not. And it was so effective, they stopped the study early. And also, these studies are looking at the effects of taking a pill on the risk behaviors, adherence and acceptability, and what happens in terms of resistance and clinical course should they become infected, even though they had used a pre-exposure prophylaxis. Now, tenofovir or tenofovir in combination in the form of Truvada is what is being used. Now, 2010, New England Journal of Medicine looked at a 3-year study that saw that pre-exposure prophylaxis reduced the risk of contracting HIV by more than 90%. Unfortunately, people saw it as a replacement for condoms, and it actually led to some high-risk behaviors. People looked at it as an easier treatment. You know, condoms still very important. You know, behavior is still very important along with medicines. So Truvada is being used now as pre-exposure prep prophylaxis to prevent an HIV negative person from getting HIV from a sexual or IV using partner who's positive. So Truvada has been approved for pre-exposure prophylaxis. It's been very effective in preventing HIV if it's used as prescribed. It's not a morning after pill, so to speak. It has to be used consistently. When it's not used consistently, it is not as effective. And I'm sure people who have looked at any of the popular literature out there have seen these or very similar magazine articles or advertisements talking about reducing transmission through pre-exposure prophylaxis using Truvada. Now, what is it? It's $1,600. That's $1,600 a month. And again, foundations and drug company support is putting this in the hands of people. Now, if you take a look at the combination, Truvada is a easy pill to use. If you want to break it up to tenofovir or Optiva, it's a little bit less expensive. They have to pay for those themselves. So it's under $600, or one pill is $1,600. So it's about $1,000 difference. Greg, we're going to start our initial descent on our journey here with polling question number 4.
We have a comment, and I'm going to launch the poll. Maybe I'll do and people can weigh in, and then you can. I'll launch the poll. There it is. The comment, Joe, is there was a London patient that was cured, and cured is in quotations, of AIDS due to donor cells which possessed a natural occurring mutation preventing cell viral fusion. Any news on that front?
The answer is yes, and that is the final part of our presentation tonight, specifically that.
Okay. So stay tuned.
So HIV can be medically managed, but it can't be cured yet. Do we agree or do we disagree? We're hitting there. We're doing great here, Greg. Almost done. We have 93%. Okay. I think we can probably start sharing. So people agree it can be managed medically, but we can't cure the disease. Okay. Well, let's talk about eradicating HIV and curing AIDS. Okay. Now, these free viral particles have a half-life of minutes. In blood, they're very susceptible to antivirals. In a CD4 cell, they have a half-life of about a day. In Macrophages, the half-life is about 14 days. These cells die. When they die, they release the viral cells. Viral cells get killed by the antivirals. So based upon these cells, it's very curable. It will not take all that long using antivirals. The problem are the memory cells, because the memory cells have a half-life of about 40 to 50 months, and that's where the virus hides. So based upon this, it would take 60 years of treatment in order to completely eradicate the virus due to its latency in the memory T cells. And patients treated for years with therapy or undetectable viral loads, would break through with cessation of therapy. Now, integrase inhibitors have not been working. Biomodulators are trying to find ways to shake the virus out of cells. And if it was shaked out of cells exposed in blood, not in a cell, they're very susceptible. Gets killed by the antivirals. But there's something called chemokine receptor 5 antagonists. Chemokine receptors, that's where the virus binds. All transmission involve chemokine receptor number 5 on the CD4 cells. And there's an experiment of nature, about 2 to 5% of Caucasians, mostly Northern Europeans, have the CCR5 mutation. And people who have this or homozygous mutation have a healthy immune system and are very resistant to HIV infection, because HIV can't bind to the cell. If it can't bind to the cell, can't get into the cell, can't infect the cell. So the binding site's not available. Now, you talk about the London patient. It was first the Berlin patient, Timothy Ray Brown. He was cured of his infection because he received 2 bone marrow transplants to treat a separate disease, separate cancer. He had leukemia. Now, the bone marrow he received came from a donor who carried this mutation, the CCR5 delta 32 mutation, and that immunity was transferred to Brown. So a trace of the virus was seen in his blood a few years later, but were undetectable even though he wasn't on treatment, meaning that he was essentially cured of his infection, according to his clinicians. But now he was given very harsh chemotherapy. He nearly died. He was put into a medically induced coma, and he received massive destruction to his immune system. Now, Timothy Ray Brown, he just died a few months ago, but he did not die from an opportunistic infection. He did not die from AIDS. He died from cancer. Now we have the London patient, which was just brought up in that question, who's anonymous. He had Hodgkin's lymphoma, underwent bone marrow transplant from somebody who was a CCR5 mutation donor, and he got less aggressive immunosuppression, not nearly killing him. So he stopped antiretroviral drugs in 2017, and he still remains cured with undetectable levels. So transplant destroy the cancer cells. They transplanted immune cells, which are now resistant to HIV, and these patients don't nearly have to die to be cured. 2016, a new set of HIV positive patients have fallen to very low levels after getting stem cell transplants similar to Timothy Ray Brown's. And there's a study called the EpiStem, now called EasyStem, which looks at potential for an HIV cure using stem cell transplantation. Everybody in this project needed stem cell transplantation to cure some severe blood disorders, and they're also infected with HIV. So transplanting from donors who have the CCR5 mutation seems to confer an immunity to HIV in these patients who are already infected. Now they're tracking about 38 infected patients who have received bone marrow transplants. 6 are from donors without the mutation. London patient was number 36 on the list, and there's also a Dusseldorf patient who's number 19 on the list, who's been off antiviral medicines since about March of 2019. He is considered the number 3 patient cured of HIV. So right now, we consider there are 3 patients who have been cured of HIV. So all the HIV infected patients received a stem cell transplant, had a significant reduction in the viral reservoir. Now, this has not been demonstrated in all the cures. These minute level of virus have been seen to date that were not considered competent enough to actually replicate or get a foothold. So time will tell, but it is a curable disease. Three people have been considered cured: Timothy Ray Brown, the Berlin patient, the London patient, and the Dusseldorf patient. And there's a handful of others who have gotten treatments, and the treatments have involved bone marrow or stem cells from patients who have the CCR5 homozygous mutation. And without the chemokine receptor, the virus can't fuse to the cell. They can't fuse to the cell, can't inject into the cell, can't infect the cell. And the antiretrovirals are actually very effective when the when the when the virus is free in the blood. So only time will tell, but I think we have to consider that HIV is a curable disease. Greg, I think we have touched down, we have landed, we are taxiing to the gate. That is the end for me.
That's great. No other questions have come into the chat box. There was just the one comment slash question there. So I'm
And
gonna.
it was a great comment slash question, and that came from somebody who clearly was very well versed in this, and that led into the last part, which I actually think is amongst the most interesting part of all of this, and the fact that we can actually cure it.
So, with that being said, thank you everyone for attending HIV and AIDS, what every optometrist needs to know. Joe, you did a great job as always. This is usually a required course, and I'm usually lecturing in another room, and so it's the first time I got to hear it. And as always, you brought great knowledge to the optometric community. So thank you.
Thanks, Greg.
And we're getting looks like.